noticed, Dr. Aisha from Egypt and Dr. Hala Jamantin, also from Egypt, are not available. They could not come. So there will be mild change in the schedule. Luckily, Professor De Fronzo, I think he will, not now, Prof, will replace that missing lectures. I would like to welcome Professor Paolo Coselli from Italy, who will talk about gestational diabetes, what's new. Do we have here anyone who knows how big is the problem in Palestine, gestational diabetes? No one? Okay, Prof, you can start.
Good morning, and yes, I try all my best to be on time. That is a secret, to be on time and pay for respect to other speakers. Now I'm going to talk about gestational diabetes. What's new? That was the title that was assigned to me. So that was a challenging title. So I thought this is my conflicts of interest. I will focus on three major aspects: the dietary modification and increased physical activity. And diets today are of great interest in the population. So there are many different diets, and all journals dealing with diets are now improving their impact factors. That means that diet is a very hot topic. Then the issue of metformin, because more and more data are emerging that in certain pregnancies with diabetes, metformin may be used. And also you will have some data on glyburide that is also used in pregnancy. And then, of course, you say, well, why about that? Because usually that is not the case. Insulin is the gold standard for pregnancy. And then, finally, I'm going to talk about technology that, as you know, is affecting lives of patients with diabetes and, of course, also diabetic pregnancy. Now, for those of you interested, please have a look at this review published in Nature Review 2019 by McIntyre, where there are a lot of very up-to-date information about diabetes and pregnancy. So this is a very good review, and if you are interested, please have a look at that. So now there are, as you know, one problem with diabetic pregnancy is different classifications. There are different groups. The gynecologists have their own classification, the diabetologists have their own classification, WHO has their own classification. By all means, the experts in the field may be confused, and usually they tend to use the classification they are familiar with. But then, just looking at this review, I found it and I read with great interest. You can find out, and the key point is here, is the different classification, and look at the threshold, and this is the odd ratio for having problems either with the mother or with the babies. And you can see the odd ratio, 1.5, 1.75, and 2 for blood glucose. These are fasting in milligram 90, 92, and 95. So try to think for a moment the potential difference between 90 and 92 milligrams fasting when you have a diabetic pregnancy. So it's really, in practical terms, is not very much. And then you can say, well, but the odd ratio is going from 1.5 for potential complication to 1.75. But clearly, with 95 fasting, you have the odd ratio that is increasing to 2. And then these are the values for the 1 hour, the classical 1 hour glucose values after the oral tolerance test, and you can see the value and for the increased ratio. So clearly, we have to take care that small modification in glucose levels may affect either the mother or the baby. By looking at the country-specific prevalence of gestational diabetes according to different diagnostic criteria, you see how complicated the issue is, because the different color represents a different classification. And then if you are very strict, very, very strict, you can have that 30% of diabetic pregnancy in Norway is gestational diabetes. So, of course, that when you try to put it in real life, it becomes very difficult to say that. But that means that you are really very strict to treat for gestational diabetes even mothers that have 91 of blood glucose level fasting. that of course imply a very good national health service, very good services in hospital that is not very practical, I would say. Don't forget, I have nothing against Norway, but it's a very tiny, small country in the world with 5 million people. So it's like it's smaller than a city like London. So that is actually the value of gestational diabetes around the world. So what about dietary advice and gestational diabetes? Well, what we can say that dietary intervention is definitely the first therapeutic strategy for a diabetic mother, potentially gestational diabetes mother. If good glycemic control is not achieved, clearly insulin is recommended. Then, if you look at what, say today, the impact of different types of dietary advice, and I give you some data, is unclear. So we do not have clear evidence that one specific diet is the best for gestational diabetes. Did you know that? Well, that's the point, that you always think that there is a very good diet, but of course diet, you cannot implement a diet unless you consider different factors, like where these people live, what is the potential health care system that help mothers to have a proper follow-up during pregnancy and so on. So it's difficult to say, I applied that diet. If you have no evidence-based data suggesting that that diet is the best. And indeed, in the Cochrane by Middleton database review, I just compared some of the most fascinating, because they are very fashionable at the time, diets available for gestational diabetes. The low moderate glycemic index versus moderate high glycemic index diets, 4 trials. And then you can see the results, looking at the odds ratio. 2 trials, no clear differences observed for large for gestational age, severe hypertension or hypereclampsia, or cesarean section. If you look at the second one, energy restricted versus no energy restricted diet, 3 trials. 3 trials, 117 women altogether, no evidence for differences in perinatal mortality or preeclampsia or cesarean section. What about DASH? DASH is a very popular diet for hypertension, and we know that hypertension in pregnancy is an issue. But if you look at the dietary approaches to stop hypertension versus diet versus controlled diet, there were no clear differences observed for preeclampsia. However, there were fewer cesarean sections in the DASH diet group. So this is at least one significant effect with this diet. What about low carbohydrate versus high carbohydrate diet? You know that there is also very fashionable high carbohydrate diet, of course, absolutely full of fiber, with over 35 grams a day of fiber. So you compare the low carbohydrate versus high carbohydrate. No clear difference seen for gestational age, for perinatal mortality, maternal hypertension, or cesarean section. Then another diet, the high unsaturated fat versus low unsaturated fat diet. No clear differences that were large for gestational age, no preeclampsia, no changes in hypertension in pregnancy, no change for cesarean section, and no differences in diabetes at 1 or 2 weeks. So even that, it doesn't work. Low glycemic index versus high fiber, moderate glycemic index diet. 1 trial only, no clear differences for both large gestational age, so either for the mother or for the, at the time of delivery. Are not finished. So you see how many trials with different diets have been done. High diet recommended plus diet-related behavioral advice versus diet recommendation only. No clear differences observed for large for gestational age or cesarean section. Soy protein, another interesting area. Means a lot of patients think that soy is good for diabetes. Soy protein enriched versus no soy protein in diet. 1 trial, no clear differences for preeclampsia or cesarean section. High fiber versus standard fiber diet. 1 diet, only 1 trial has been done, no primary outcome reported. And then the issue of ethnic specific versus standard healthy diet. Only 1 trial, no differences for large for gestational age, neonatal composite outcome, and gestational hypertension or cesarean birth. So, unfortunately, what's new is that there is no good specific diet that we can adapt for patients with gestational diabetes. I think that the data are very strong to say that, and of course this is going to be personalized, because the mother has to be happy during pregnancy. You cannot make a pregnant lady unhappy about giving a diet that is not her diet. So I don't think personally you should change diet, but just find to follow the diet that the mother is doing, providing that the mother is not obese, and then try to keep going according to what data say that all these diets may be used successfully. What about physical activity and gestational diabetes? Well, I think that physical activity is another area of great interest. Have you seen how many gyms around the world are now available for patients? Everybody wants to go to the gym. If you are not going to the gym, you are out of date. You have to go to the gym. And so even during pregnancy, gym is an important step for a very good outcome. And data here are of interest, and there are some novel information available. Now, we have some clear data that reduce risk of excessive weight gain, gestational diabetes, preeclampsia, varicose vein, deep vein thrombosis, and lower back pain can be obtained with physical activity. It reduces the duration of labor and complication in childbirth, and also there are potential benefits for the fetus as shown in this slide. However, there are no clear guidelines, again, of what type of physical exercise you should perform. Now, we live in a world, as physicians today, of evidence-based medicine. And so we have to recommend data, we have to recommend guidelines, or we have to tell our patient what is the evidence-based. And so again, when you try to extrapolate information for this trial into real life, is difficult. It's difficult, because data are a bit contradictory. Now, let's see, this is a nice meta-analysis and study done by Nicoletta Di Biase. She is working in Rome, publishing nutrition, metabolism, and cardiovascular diseases, looking at different outcomes of gestational diabetes according to the type of exercise performed. So what you can find here, and then on the right-hand side you give briefly the summary, you can take a reference if you are interested, that the majority of intervention studies shows that exercise decreases both fasting and postprandial blood glucose compared with control intervention, and improve insulin sensitivity and increase glucose uptake, and very relevant at the end of the day is what happened at birth. There is a reduction of 58% of macrosomia, and a preterm delivery 34% risk reduction. So that's fine. So we know that, and this is consistent data, 58% reduction of macrosomia. And we know how macrosomia is a major threat for the baby. So, but what type of exercise? Now here, regular, moderate, intensive, resistant, and aerobic exercises. 3 training session week, 50-55 minute session. Okay, so this is what it's about. This is the physical exercise, 3 training sessions a week. So reduction, 58% of GDM-related risk or having a newborn with macrosomia. In exercise and control group, respectively, you see the odd ratio there. 34% reduction of the related risk of having acute or elective cesarean delivery. In exercise and control group, respectively, you have the odd ratio there, 130 to 129. So regular moderate exercise performed during the 2nd and 3rd weeks, according to this protocol, could be really beneficial for the mother. We now move to the oral apoglycemic agents. Is there something new? What about metformin? Because I think metformin is the issue. Many mothers don't like insulin. There is no question about it. In particular, if they don't take insulin because they have this mild form of diabetes. So having insulin, immediately think, well, my God, it's difficult. I'm going to hypoglycemia, so it's bad for the fetus and so on. So what about metformin? Now, there are data, interesting data. This is a comment why metformin may be considered. Definitely when there is no adherence to diet and exercise, and when the mother definitely needs to be treated with liquid insulin. Insulin definitely can achieve an appropriate metabolic control. It is added to management if fasting glucose is above or equal to 95. Metformin and glyburide are increasingly used, but they are not approved by the FDA. So still are not licensed for the use in gestational diabetes. Now these are the data, the retrospective and prospective core studies of metformin use in GDM. Well, I think that the number of ladies that have been treated with metformin during pregnancy is quite considerable. And the results, as you can see, if you can read the slide there, definitely say that you have a lower risk of complications, higher rate of induced labor or planned cesarean, lower mean birth weight, great need of phototherapy for neonatal jaundice. These are the negative use of metformin in gestational diabetes. But definitely, there is a greater maternal weight gain with insulin versus metformin. So that is the point that we have to take into consideration. In particular for ladies that tend to put on weight, the use of insulin clearly helps them to put on weight. This is a meta-analysis looking at glibenclamide, metformin, and insulin for treatment of gestational diabetes. I had recently one young lady treated with glibenclamide because she was pregnant, but she didn't want to take insulin at all. She was really against insulin. And she was treated with glibenclamide, and that pregnancy went very well. That was my first lady treated with glibenclamide. Usually thinking about giving glibenclamide, a drug that is even not given to type 2 diabetic patients today, but then it works well, and the baby was born recently. Everything went very, very well indeed. So if you look at this meta-analysis, in women with gestational diabetes is clearly inferior to both insulin and metformin, while metformin performs slightly better than insulin, in particular in the body weight. Now, what about obesity? Because, of course, you have gestational diabetes, but you have obesity. This is a meta-analysis published recently in Diabetes Meta-Research Review, and the use of metformin in obese ladies was accompanied by a lower maternal weight gain, with a significantly lower incidence of preeclampsia and admission to the neonatal intensive care. And then this analysis suggests that the use of metformin in obese pregnant women with normal glucose tolerance is really a good thing to consider, in particular to avoid body weight. So at least, of course, it's not, again, licensed, but metformin has this new potential interest in use in obese women. And there are some guidelines. And if you look in red, what is written here, American College of Obstetricians and Gynecologists say insulin is first line. If glycemic control is not attained with no pharmacological treatment, consider metformin if patient cannot take or decline insulin. The International Federation of Gynecology Obstetrics say insulin should be considered as first line, but insulin, glyburide, and metformin are safe and effective treatment option during second and third trimester. The UK NICE say if insulin is not for some reason untolerated, metformin is used if glycemic targets are not attained with lifestyle modification, and insulin is used if metformin is not tolerated or acceptable to the patient. The Endocrine Society is saying metformin can be considered in women who decline or cannot use insulin, and the women in India with gestational diabetes strategy guidelines say metformin may be used if insulin is not available. And then International Diabetes Federation said insulin is the treatment of choice, but there is now adequate evidence to consider the use of metformin in women who have been informed of the possible risk. So, as you see, there is a window open for that treatment. Finally, just a couple of slides on continuous glucose monitoring and smartphone technology in GDM. Very few data. You may guess, very few data compared to what is available. But of course, there are a lot of trials ongoing. I saw on the ClinicalGov a lot of trials going. This is some of the previous study published in the last 2 years. As you can see, the 2018 papers that, of course, frequency of blood glucose monitoring, fingerprint versus now the new non-invasive devices definitely help the mother and help in the monitoring. Of course, don't forget that during pregnancy, most of these data are followed by gynecologists that are not very familiar, the gynecologists, with the new devices. We have to teach them about these new devices to see the profile on the computer rather than a finger prick. You cannot believe, but gynecologists with these new devices are not familiar at all. So before you actually say, okay, followed by the gynecologist, talk to gynecologist and explain to the gynecologist what he or she should do in monitoring glucose according to these new devices. So the smartphone technology is extremely helpful for caregivers because you can actually send data. If you are in a great center, we have now a cloud, our own cloud, where all the diabetic pregnancies send their mothers send their data, we see the data and we communicate directly without seeing the patient. And so we can monitor and we leave the gynecologist separate. So we monitor, we send information together to the mother, to the gynecologist by remote control. So I think that this is probably a good way. I'm nothing against our colleague gynecologists, but I think that the point is that it's difficult for them to follow this new technology applied to diabetes as is going on today. So in conclusion, dietary intervention is the first therapeutic strategy. There is no specific diet that should be considered either for the mother or for the child. Aerobic or resistant exercise performed at moderate intensity at least 3 times per week safely helps to control postprandial glucose, another measure of glycemic control. And exercise intervention has many potential effects, in particular less preterm delivery, less microsomia. And metformin, I think we have now plenty of data to say that it's safe, in particular in those patients, in practical terms, where they have a very mild gestational diabetes. Very mild gestational diabetes is something that you may consider. And we look forward to have the new trials results soon with smart technology, in particular in quality of life, because don't forget the importance of quality of life in diabetic mothers, because this is an issue that we have to discuss all the time, because they are very skeptical, they don't have children because of diabetes, but then with this new technology, it helped them a lot. Thank you very much.
Thank you, Prof. Excellent and on time.